until I reviewed the slides the other day. And it's really very interesting topic, and I think will stimulate quite a bit of interest. And since food allergy is becoming clearly one of the dominant areas in our specialty, a very timely topic here. So food allergy-induced anxiety from David Jeong over at VM. So David, go ahead.
Thank you, Len, and it's good to be with everybody. Happy Tuesday. So as Len said, this is my topic. I was one of the speakers this year who got to choose their own topic, and this one just sort of kept coming up to the top of mind because it's something that I deal with a lot, and any of us who treat food allergies probably see it at least a little bit, if not more. And so I'll be more than happy to share some of the things that I've learned and some of my experiences. But I think more importantly, I'm hoping to leave some time and generate some conversation at the end. I'd love to hear anybody's thoughts or experiences, things that have worked for them with their patients and things that haven't worked. So that's what we will try to accomplish this morning. Let me move on here. So disclosures, I have no relevant disclosures for this discussion today. The agenda that I want to share with you in outline form here, just a brief review of the situation and the background with regard to food allergies, and then kind of quickly going into discussing food allergy-induced anxiety in terms of the prevalence and some of the mechanisms associated with this issue, the causes associated with this issue, and then just a review of some of the cues and tip-offs, things you should be looking for in your patients who have this issue. And then finally, we'll dedicate a decent amount of time to management strategies that you could consider in your practice. Before we start, I came across this little tidbit of evidence that I just had to, I felt I had to share as a motivation. Rubis et al. From 2014 published this statement that training allergists to identify anxiety in their patients using a 1-hour educational workshop similar to this did not improve their ability to recognize anxiety symptoms. And I just felt that this group was going to buck this statement and really come out the opposite way. So I declare on this day that our group will ignore this evidence and become experts in this topic in a span of the next 56 minutes. So I'm going to start with a case. This is actually a real patient. I did change his name for privacy matters, but a real patient, a real experience that I dealt with. It's been a couple of years ago now, but it's a 15-year-old male, established patient that I've known for a while with a peanut allergy, which was originally diagnosed as a toddler, came back for a follow-up visit with his mother. No accidental exposures to peanuts since the last visit, which was 3 years before. And he comes back with his mom, really with the main concern that he has since developed severe anxiety that is centered on his peanut allergy. The initial reaction he had was generalized hives upon one of his first exposures as a toddler. And the last time we performed the test on him was 3 years before, and it was a skin test measuring 12 by 40 millimeters. Though appears clearly positive, I did not obtain any blood work at that time. Got a detailed history with regard to the anxiety, and the family already is aware that the anxiety is based on a fear of accidental exposure to peanut. And he also mentions on a couple of occasions he's really fearful of dying from an allergic reaction. There's already significant distress, major impact on quality of life, and specific things he mentions were a fear of eating, fear of social situations, fear of public places, and a fear of relationships, and a fear of getting a girlfriend. I had a few questions about how to manage that, and that's sort of a different psychology lesson altogether. He had already consulted with a psychologist, and they had already come up with a treatment plan that includes a combination of psychoeducation, cognitive behavioral therapy or CBT, and medications due to the presence of some OCD symptoms. And the family and the psychologist both request that we accomplish a multidisciplinary visit that is between me, the patient, the mother, and the psychologist. So we do have that visit, and that is in my clinic. We dedicate nearly 40 minutes for that visit. And what we accomplish during that visit is extensive psychoeducation for the patient and the mother. And specifically, among other things, we talked about the clinical manifestations of allergic reactions and how the severity of reactions can differ based on the route of exposure. After that visit, we agreed to get some updated testing, and we do a component panel and find that his ERA H2 IgE is 1.9. No other components that were remarkable. We didn't have the access to ERA H6 at this time. Caleb then agrees, based on my prompting, to undergo a food challenge with a somewhat low ERA H2, understanding the potential clinical benefits of undergoing a challenge and the psychological benefits. He agrees to it. We get to the challenge, and he is able to consume several steps, cumulatively 2 grams of peanut protein, and then he eventually develops hives, nasal congestion, rhinorrhea, and conjunctivitis. And we got him to recover quickly with a dose of epinephrine. So that's our case. Launching into some background here, we'll come back to the case a little bit later on. So we all know these numbers. Food allergy, 8% prevalence amongst kids and 4% prevalence amongst adults. And among other things, current management involves evaluation of food safety and vigilance against preventing accidental exposure. And of course, this can have a significant impact on both patient and caregiver quality of life. Avoiding the allergen, managing emergencies requires behavioral skills, emotional resources to cope with the challenges that comes from both patients and the caregivers. These folks rely on the public to provide accurate information on food ingredients, and requires trust in any caregiver to recognize and treat allergic reactions. So we're calling on patients and their families to trust a lot of external people and systems. And as you can imagine, that can lead to a lot of questions and possible uncertainty that develops over time. So this concept of balanced integration, you see this term in literature a fair amount. The idea here is that patients and caregivers hopefully achieve what's called a balanced integration or an equilibrium of appropriate vigilance or even anxiety, while not letting the allergy deter engagement in appropriate activities or to significantly disturb quality of life. So now discussing anxiety induced by food allergies, it's a constant variable in those with food allergies. It's highly understudied. If you really dive into the literature, there's not nearly enough. This ICER report states that patients and caregivers often lead a lifestyle heavily impacted by fear and anxiety when it comes to food allergies. It's widely believed that some degree of anxiety is adaptive and necessary, but it becomes a problem when you disturb the equilibrium or you can't achieve balanced integration between vigilance and the ability, your ability to function becomes disrupted, and that's really when this becomes an issue. This NHANES survey between 2007 and 2010, excuse me, looking at both kids and adults. There were 14,700 plus individuals, 12 and older, that were surveyed. Almost 10% of these individuals reported at least one food allergy. And of course, this is self-report, not necessarily physician confirmed. And 25% of those individuals with a self-reported food allergy reported 7 or more anxious days in the previous 30. and so it happens and it occurs in a significant portion of the time for these individuals. And the trends that were noted, these were individuals most likely to be female, more likely to be female, asthmatic, and lower income. And interestingly, in the same survey, food allergy was not associated with anxiety in adults. Could be a lot of potential theories for that. One of the leading theories from this survey was that as food allergy individuals age into adulthood, they start to learn how to cope, and perhaps those anxiety issues diminish over time. What are some of the risk factors for food allergy-induced anxiety? Well, first of all, if you have a personal history of anxiety already or anxiety disorder, or if there's a family history of anxiety disorder, something to look out for in your patients. Female over male, although it obviously can happen in either gender. If there was a previous traumatic event as the patient perceives it, especially anaphylaxis due to a food allergy. And also if you have children who have parents with high anxiety and or an overprotective parenting style. So these are some of the most prominent risk factors noted in literature. So how does this issue develop? Another term you tend to see thrown around is this term called spiral of negative reinforcement. Over on the left here, oftentimes anxiety will develop after some kind of a scary or traumatic event. And after that point, there's a fear system that begins to perceive even low risk situations as potentially real and harmful threat. And then due to this fear response, children and or the parents start avoiding situations in which the risk of exposure to allergens is low. And that leads to temporary relief and the belief that their behaviors are actually working, which can then further increase their anxiety over time. And eventually what happens, the key abnormality here is that risk assessment becomes increasingly faulty. And the picture over to the right depicts a similar concept here. Other factors that can reinforce the fear response. If you have parents, caregivers, providers reinforcing these behaviors or even modeling these behaviors, and I do call out providers. Sometimes it can come from the provider level, so something we have a responsibility to be aware of our practice styles. Time passing without the recognition of the matter, and certainly if time passes without treatment, you can let this kind of get out of hand. And then the safety behaviors, behaviors that are not necessary to stay safe, but give that feeling of safety. I was referring to that in the previous slide, and that is another way to reinforce the anxiety. Some examples of these behaviors include constant label checking, excessive questioning of food preparers, and then repeatedly seeking reassurance. I do want to make a quick comment here about trauma. It's a term you hear or you read a lot and you hear a lot, and I think it's important to define trauma with regard to timeline, because it can influence and change what you offer or what you want to do for your patients, right? So anxiety and avoidance are appropriate immediately after a traumatic event. So if something happens like an anaphylactic reaction, it's almost expected that an individual and or the family may experience some degree of anxiety and avoidance. And in that immediate time period, it's not necessarily a time to start, referring to mental health professionals or, executing your own mental health strategies, but really more than anything, just offering supportive, compassionate therapy. And I do call out this handout, which you all can refer to at a later time. This is a handout that Mount Sinai prepared that they published in literature that is actually one of the better handouts that I've read in terms of explaining this particular issue. So it's something you could, use for your patients. According to DSM-5, if you have these negative behaviors for at least a month, that will qualify as PTSD. And of course, at that point, that might be a time frame for you to consider either yourself or through the help of a mental health professional or therapist, diving deeper into possible treatment. And if you have issues of anxiety that last for 6 months or longer, then you delve into the phobia territory, which again, definitely by this point, if not already, you want to think about getting help for those patients. So I wanted to include this list of fears that I've heard from patients, or things that have been reported in surveys. Patients will tell you. The first one there, fear of adverse reaction, is by far the most common issue or fear that people with allergies bring up. Next is a fear of casual exposure, meaning incidental touch or even inhalation. And I wanted to call out a couple of these statistics here. According to one study, 51% of children reported a severe type of fear associated with casual exposure. And in the same study, there were teenagers indicated that touching the allergen actually was higher risk than ingestion. There's clearly, a fear that, according to this study, was based on some misunderstanding of how allergies work. Stress from avoidance and managing an exposure, fear of dying, fear of using epinephrine, fear of skin testing, food challenges, fear of going to the ER, fear of food allergy treatments in those relevant individuals, and then a fear of social rejection or bullying, among perhaps others that I have not included. These are the most common reasons or fears that people bring up. Quick word on bullying, very common issue. There is just a little bit of literature on this. One study reported that 24% of students report being bullied, teased, or harassed because of a food allergy. Another study showed that 32% of children were bullied at least once due to a food allergy. So very substantial number of kids. It is a risk factor for anxiety, depression, suicidal ideation, school avoidance, rejection, diminished quality of life, and even stress among parents. So in a very quick manner, what should you do? It is something we should ask about, and it's something that we can quickly check on when we're meeting with our patients and families. Ask the parents and the children about whether bullying is present, and if it is, evidence-based recommendations that parents really should intervene at their child's school. Get the school administrators and teachers involved. That was actually shown to reduce the chances of further bullying. So what are some tip-offs for anxiety? We're looking for excessive safety behaviors, looking to see if food allergy is at the center of the family or becomes the child's or family's identity. If families are asking other people or institutions to take excessive measures, not allowing their kids to participate in activities or visit friends or family because of the allergies. If you see unintentional weight loss, of course, the differential can be broad for that, but food allergy anxiety could be a consideration. If you see problematic eating behaviors, avoiding foods, restricting foods that are beyond necessary, and if they just lose interest in participating in activities that they once enjoyed. So now I just want to talk a little bit about management. And this is probably where we could have a lot of conversation, in terms of sharing ideas. I just want to touch on a few different areas here in terms of how one could manage. Number one is utilizing validated scales in our clinical practices, and I'll touch on that in a bit. If we cue in on anxiety in our patients or families, to the extent that you can accomplish this in a relatively short period of time, trying to differentiate whether the anxiety is because of the food allergy, or if it's a generalized anxiety disorder, or if there is anxiety due to other issues or other life events. And then this concept of psychoeducation, and then finally cognitive behavioral therapy. So I'll try to launch into some of these issues now. So with regard to validated scales, there are a number of scales that have been published, too many for me to include all here in this talk, but I do want to call out a couple of scales that are perhaps worth noting. The first one here, called the Food Allergy Quality of Life Questionnaire. It's an internationally validated scale, initially developed in the early 2000s. It's become widely used in numerous studies that directly study anxiety, or if you have any outcome studies as part of therapy trials or whatnot. This is typically the go-to scale. There are 3 domains, as you see here, that are covered by this scale. One is emotional impact, second, food anxiety, and third, social and dietary limitations. I included some references, but did not take the time to include all the questions here. Very powerful scale. It's actually, there are different versions of this for for young children, for older children, for teenagers, and even for the parents. And of course, if you're talking about really young children, the parents are going to fill those out as well. But you'll probably see this term a lot if you dive into the literature on this topic. And then the next scale that I want to bring up is the Scales of Food Allergy Anxiety, or SOFA, which came out of CHOP, validated scale, and probably the most recent to be published just in the last year. There are both child versions and parental versions, and they both have a full and brief version for each category. And I did pull those up into screenshots here for your reference. I'm not going to go through all these questions now, but you get an idea of what these surveys are all about very quickly. So the first one here, we're looking at the child full versions. There's 21 questions on this. And then moving on here, we have the child version of the child brief version, which is 14 questions, which this perhaps for many of us in busy practices, this might be something to consider. And then on the next slide here, we have the full parental version. Again, that's 21 questions here. And then finally, the parental brief version, which is just 7 questions, a little bit easier. So again, I won't go through all the questions here, but certainly keep these slides if you feel inclined, and you can get an idea of the questions from here, and also find the literature source as well. So yeah, I mean, this can be kind of in summary on this, an objective way to get a feel for where your families are at, where your kids are at. I was not able to find any specific score cutoffs, kind of like you might get with ACTs and other surveys. But some of the literature that CHOP published, especially with the full versions, would indicate that scores of 30 or higher might indicate problems with anxiety. Okay, and just moving on to the topic of psychoeducation. And this is something that I've personally leaned on and used in my practice quite a bit. I think it doesn't always work, but it certainly helps many children and parents going through this issue. The idea here is to empower patients and parents with education surrounding food allergies. And that is because, people with food allergy-induced anxiety often have incorrect or distorted views on how food allergies work or what they're all about. So the idea is to educate patients and families about various aspects of food allergy, including the immune system, the pathophysiology, what are allergic reactions, the potential route of exposures and how the severity can differ, going through the safety technique and indications for using epinephrine. And then in some cases, I've had to just, talk about fatality rates because what people believe is true is often very far from what the actual incidence is. So,
David, what is that would seem to be a powerful thing. What is that rate? Do we know?
Yeah, I mean, so based on the data we have, it ranges anywhere from 100 to 200 fatalities per year from food allergy induced allergic reactions.
But do we know the denominator on that, like out of a million food-induced reactions, or how to put that in scale?
Yeah, admittedly, I don't have an exact number on that, but it's going to be a huge denominator in terms of if you're talking about anybody with allergic reaction or food allergies, and specifically those with food allergy-induced anaphylaxis. I would imagine we're going to be, in the hundreds of thousands, if not, at a million or more. And this, of course, would include, any anaphylaxis, not necessarily just severe life-threatening.
Good.
Yeah. And then, making sure that you use developmentally appropriate language to match the your target audience. And of course, therapists and allergists can do this or can accomplish this, and I've seen it go both ways. But when it comes to food allergies, oftentimes we are, as allergists, the best position to provide this psychoeducation because so much of it is trying to explain the immune system, and as smart as our mental health therapy colleagues are, they just don't know this stuff, right? So it oftentimes falls on us. And I throw in here that obviously this is a huge topic, and you may not be able to accomplish all this in a matter of 3 to 5 minutes. Having dedicated visits to this, if you feel inclined, often are necessary. As far as cognitive behavioral therapy, or CBT, this is one of the major ways that this issue is dealt with. It's a form of psychological treatment that's meant to change faulty thinking or behavioral patterns, leading to conditions like anxiety, as well as depression and addiction. Learning to recognize one's distortions in thinking, gaining a better understanding of one's behaviors and fears, developing confidence in self-management skills, and then restoring your ability to assess risk appropriately. And as perhaps complex or technical as that might sound, allergists can definitely be a source of CBT or provide CBT in the appropriate situation. So exposure therapy is a type of CBT that is probably the most widely used when it comes to managing food allergy-induced anxiety. It's a process by which individuals directly challenge catastrophic anxiety-driven beliefs or scenarios. These patients gradually expose themselves to situations or objects that arouse fear and learn that the feared outcome does not happen. And so the ideal goal is that the anxiety subsequently feels increasingly manageable. And you know, when you think about CBT, you know, you might think about, you know, relaxation techniques or cognitive restructuring. But when it comes to food allergy, CBT seems to be far more effective when you actually incorporate some sort of exposure therapy that is customized to what the patient struggles with most. So different examples of exposure therapy, and I've had experience with most of these, as probably a lot of us on this call. Casual exposure by touch or inhalation. I've sat in offices and actually, you know, smeared allergen onto people's skin, or had it, you know, near them, and you know, that often can trigger some minor reactions, cutaneous reactions, but never anaphylaxis. And a number of studies have actually looked at this and confirmed that anaphylaxis does not occur when it comes to touch or inhalation. Proximity challenges, kind of similar, having the allergen perhaps in a room, and you might do this in the format of a challenge in which you start a certain distance away from the patient, and every few moments you move the allergen closer and closer, and you know, confirm that for the patient that nothing will happen. Self-injection of epinephrine, I have done that a few times and have found that to be wildly successful in alleviating those fears. Oral food challenges can certainly be helpful in terms of providing more clarity for patients in terms of perhaps the threshold of reaction, or the type of symptoms that they could possibly experience, and taking a lot of the mystery and assumptions out of the equation. You know, oral immunotherapy, there are definitely some literature. So there's a nice meta-analysis from last year that showed that OIT can certainly improve health-related quality of life, especially once an individual reaches maintenance and has fewer issues. And similar for epicutaneous immunotherapy, data from the phase 3 DBV trials for peanut that showed improvements in quality of life. But just several of perhaps some of or all of the examples you can consider in this domain. A couple of other tips here. If there is a fear of uncertainty, which you might hear from time to time, we want to promote the message that safe enough is okay. You know, we all take risks, and a lot of the things that we do every day, and we can never say that something is zero risk for a problem, but yet we do them anyways because we need to, and that's something we want to remind patients who deal with this issue. And one tip I got from a therapist is to create specific lists for individuals based on what's safe, probably safe, or unsafe, so that people can refer to those down the road and understand and remind themselves that there are definitely certain things that are okay to do. We want to validate for patients and families that their fear makes sense, that it's not inappropriate, but then also giving the psychoeducation that they need to help them be empowered to know when to override that fear response with facts, with an understanding of how the immune system works. Making sure that families have that green light to start doing activities or things that they cut out unnecessarily. And a very important point, in my opinion, is if you pick up on parental anxiety, it's best to be direct with that and to actually call that out with the parents and encourage them to get help for themselves as well if the conversation goes in that direction. And you know, a quick bit of information here on when to refer out. Perhaps as you hear this information in the previous slides, you might have thought I would have referred a long time ago before getting to this point even, but which is fair. Not everybody will have the bandwidth to deal with this, but these are some definite you must refer out. among perhaps others not on this list. One is going to be if the symptoms you're seeing are severe or progressing quickly, causing significant dysfunction, refer out. If you see OCD tendencies, refer out immediately, because OCD is a condition that will worsen if you do not treat it. And it is often necessary to use medication to treat OCD, which probably none of us on this call would feel comfortable doing. And then also problematic eating habits with malnutrition. And I call out this particular condition called ARFID, which I've seen a handful of cases of this, and perhaps others have as well, avoidant restrictive food intake disorder. It's a condition in which people stop eating, whether there's a sensory issue or a fear of a negative outcome like an allergic reaction or vomiting, or for some reason they just lose interest. But it also has to be accompanied with signs of malnutrition, nutritional deficiencies, severe weight loss, and then finally you have to make sure that there isn't any other explanation besides ARFID. And so gosh, in the cases that I've seen of this, it has led to very severe eating disorders. And so if you see that in your patients, definitely refer out. And these are a couple of websites that you can use or you can give your patients as ways to look up mental health professionals in our area. And just a reminder to think about a multidisciplinary approach. Consider that, visit with yourself as well as a therapist and family. That model has, I've done it a handful of times and that model has worked really well. Consider different combinations of people you visit with, whether it's the parents alone or, if old enough, the child alone or everybody together. Develop a partnership with the therapist. I do believe that is definitely more powerful than if the right hand isn't talking to the left hand, and then consider customizing that treatment plan based on the individual. All right, so here's the case again. This is our guy, Caleb. It turns out that the food challenge that he had, if you remember back, he had that systemic reaction, served as a form of exposure-based CBT for him. And it helped him a ton, clearly, to understand what would happen when he gets exposed to peanut. He learned to some degree what his threshold could be, and that can change, but knowing that his threshold was fairly high at 2 grams was a confidence booster for him. And it also reinforced that casual exposure is really indeed low risk. His family's from Israel. He was terrified to go to Israel to visit his extended family because everybody eats peanuts there, and he finally went and was happy about that. He ended up getting a girlfriend and told me, just shared a lot of details about them kissing and how that was okay in terms of allergies. So that was good for him. But overall, he's actually doing great. I saw him recently, and he's just a totally different guy now than he was a few years ago. All right, some final thoughts here. So it's a common problem, as I mentioned. It's understudied. We as allergists are often best positioned to prevent, screen, and recognize those early signs of anxiety. We probably have all experienced that access to these mental health professionals, particularly those knowledgeable in food allergy, it's extremely limited and very expensive. And that can be tough for our patients and families. And so because of this, especially, it's, I think it behooves us to know at least a little bit about this so we can get our patients and families at least started on the path to recovery. We have seen, especially through COVID, that telehealth services have dramatically increased, like all other healthcare specialties and organizations. There is actually ongoing work to establish a national license for mental health professionals, which could then increase access even beyond state lines. And as recognized by multiple experts, there needs to be perhaps a subspecialized training for food allergies when it comes to mental health care. And there you have it. You are all equipped. You are all quote unquote psychologists. I just want to acknowledge Jennifer Teninenko, has been a tremendous colleague for me, and I've learned a ton from her through the years. And I think she's probably partnered with many of you in the community on anxiety related issues. So she did provide some valuable information for me for the talk today. Some references for you, and finally, our word of the day. Thank you, everybody. So yeah, if now is a good time, questions or conversation, I'd love to hear what people think about this and what their experiences have been with their patients, and Len, whatever else you need me to do, I'll do it.
Well, thank you very much for kind of conversation that we usually don't have when we focus these talks more on hard science, but obviously something of tremendous importance. I don't see a lot of kids with food allergy. Hopefully other people will speak up. But towards the end of your talk, I thought about another condition that we see, in which I saw a patient I remember very well, where the same thing occurs, vocal cord dysfunction. I remember a kid who collapsed on a soccer field. People thought he was going to die. It happened in Russia. He was flown back. And their very successful outcome by teaching him what vocal cord dysfunction was and being objective about it. So probably these things have even broader reach in the diseases that we see, and our specialty is the point that I'm making. The other thing,
agreed.
Yeah, for maybe the community, again, I'm not the right one to answer this, but I'd pose the question, we hoped when Immune had a product and other people actively looking in food allergy, and I know Dan Petroni has a lot of food allergy related studies. Obviously, if we had a successful product to treat this disease, that might be the single most effective thing. I'm just wondering, those in the community who treat more of this, what's our general experience with their product? Has it had any impact on peanut allergy at all in the Seattle area? Are people using it?
Well, if Dan is on the call, that'd be great. I'll just share really quickly. I've done. I think both Dan and I have done a lot of the Immune trials, clinical trials. So I've certainly observed patients, using AR1 or Palforzia, and it's been a mixed bag. I mean, I think when you look at the meta-analysis on OIT, it really does call out that the quality of life, there's a trend towards improvement as you're on therapy, but it is definitely a more significant trend when these individuals reach maintenance. And that probably directly correlates to the fact that there are more adverse reactions to OIT when you are in buildup. And as that diminishes, and there's this sense of control, as I mentioned, and this sense of safety or increased safety now that you're desensitized. I think there's definitely a real impact. I've also had patients who actually did develop ARFID, on OIT because of adverse reactions and complications and there being some anxiety. So it's a mixed bag, but I would say overall, it appears the data that we have is one of a positive impact.
Other questions or other people with experience with Palforzia? We've got a broad audience out here. Somebody must have something to tell us.
the conversation about who is using Palforzia and how many of us are, that's another 1 hour conversation right there.
Do we have other people in the audience who have used the product? This silence won't make Steve Tillis happy.